Hi, I'm Lance Frank,
And I'm Gino Hanlon.
and today we're going to be talking about lumbar spondylolisthesis. Today we're going to cover how spondylolisthesis is classified, its prevalence, how it's diagnosed, common signs and symptoms, what to expect on a physical examination, different therapeutic interventions, the patient prognosis, and specific outcome measures.
A spondylolisthesis is an anterior translation of one vertebral body on another, regardless of vertebral region. Depending on the cause of the spondylolisthesis, it may commonly occur between L3 and L4, L4 and L5, and L5 and S1.
Research suggests that spondylolisthesis is found to be present in 5.8% of men, 9.1% of women, and African American women are at a risk of 3 times higher than other adults.
There are various classifications of spondylolistheses, primarily based upon what has caused them. An isthmic or spondylolytic spondylolisthesis is caused by a small break in the pars leading to the anterior slippage. A dysplastic spondylolisthesis is caused by a congenital defect from birth in the facet joint that leads to vertebral segment instability. Traumatic spondies result from acute injury to the spine, resulting in a fracture of the pedicle, lamina, or facet joints. Pathological spondies are due to structural weaknesses inherent in the bone, usually secondary to disease or malignancy. Degenerative spondies occur when vertebral articular surfaces become arthritic and lose their ability to keep the spine properly aligned.
The two most prevalent types of spondylolisthesis are spondylolytic spondylolisthesis and degenerative spondylolisthesis. Spondylitic spondylolisthesis occurs in a 2-to-1 male to female ratio and is the most common form of spondylolisthesis. It results from bilateral defects in the pars and interarticularis in which the posterior aspect of the vertebral body separates from the anterior body. The main causes are dysplastic pars at birth, which is then exacerbated by sports with excessive loading and extension such as football and gymnastics. Degenerative spondylolisthesis is the only form that does not cause a break in the pars interarticularis. It is mainly caused by disc degeneration, facet joint arthrosis, malfunction of the ligaments stabilizing the vertebral bodies, or ineffectual muscular stabilization. Common risk factors for degenerative spondylolisthesis are age, female sex, pregnancies, African American ethnicity, generalized joint laxity, and anatomical predisposition.
Evidence of a lumbar spondylolisthesis can often be found by completing a comprehensive patient history looking for notable pain behavior, a postural assessment, and palpating the lumbar spine looking for a drop-off sign. The gold standard for medical diagnosis is currently a standard X-ray. Severity of the condition is measured on Myerding's scale, ranging from grade 1, being the most mild, to grade 5, a complete disarticulation of the vertebral segments. Grades are separated by percentage of the slipping vertebral body still in contact with the segment inferior to it. Myerding's scale is utilized on top of radiographic images by physicians. An example of a grade 2 spondylolisthesis is shown here.
Typically, there aren't any noticeable signs and symptoms of a spondylolisthesis. If there are, they might present as low back pain or leg pain, numbness, or tingling. These conditions may occur unilaterally or bilaterally and can be improved with sitting or flexing forward. Often, these symptoms will be aggravated by standing, walking, or extension of the lumbar spine.
A patient with a lumbar spondy can often present with symptoms that mimic a combination of other common lumbar conditions, such as lateral recess stenoses and disc herniations. Differential diagnoses can be made with proper evaluation techniques, such as pain behavior, palpation, and imaging.
Herniated discs very rarely occur at the level of the spondylolisthesis. Most commonly, they occur at the level above the spondylolisthesis and can cause radiculopathy involving the nerve exiting under the pedicle of the subluxed vertebrae.
Patients with a lumbar spondylolisthesis may present with some of the following clinical signs: a significant lumbosacral kyphosis, a hyperlordotic posture, lumbosacral tenderness complemented with the palpable step-off deformity, complaints of pain with lumbar hyperextension, a dull back pain exacerbated by rotation and hyperextension, hamstring tightness, contractures, and/or spasms, a variety of gait disturbances, including crouching, short stride length, and an incomplete swing phase. There may also be the potential for distal neurological symptoms depending on the level of the spondylolisthesis. There may be an associated scoliosis as well as bowel and bladder dysfunction. Patients may also have a positive straight leg raise test.
Typical interventions for spondylolisthesis patients mostly include stretching the hamstrings, hip flexors, and paraspinals, strengthening of the transverse abdominis, pelvic floor, and gluteus muscles, and low-impact cardio such as biking or swimming. Activities that put the lumbar spine into hyperextension should be avoided.
There are a handful of scenarios in which surgery becomes a more viable option for treating a spondylolisthesis, such as if conservative treatment has had limited benefit. This may be the case in 10 to 15% of patients. If more severe symptoms such as progressive lower extremity weakness or bowel and bladder dysfunction develop, or if the spondylolisthesis has greatly reduced patient quality of life, a medical team may recommend a spinal fusion for faster relief of symptoms and return to prior level of function.
In terms of prognosis, conservative approaches may not reduce the slippage of the vertebrae, but it can help reduce the severity of the patient's symptoms and the need for surgical intervention. Lumbosacral corsets can also be prescribed, which can also help manage the pain, but again, won't help reduce the slippage.
The most widely accepted outcome measure for lumbar spondylolisthesis treatment is the Owestry Disability Index or Questionnaire. It is broken into 5 categories based on patient responses to a number of questions. Minimum disability patients can usually cope with most living activities. No treatment is indicated apart from advice on lifting, sitting, and exercise. With moderate disability, the patient experiences more pain and difficulty with sitting, lifting, and standing. Travel and social life are more difficult and they may be disabled from work. Personal care, sexual activity, and sleeping are not grossly affected, and the patient can usually be managed by conservative means alone. With severe disability, pain remains the main problem, but activities of daily living are now affected. The patients require a detailed investigation. In a crippled patient, back pain impinges on all aspects of the patient's life, and positive intervention is required, usually implying surgery. Finally, patients with extreme scores are either bedbound or may be exaggerating their symptoms, indicating the use of an SF-36 or other cognitive scale. Using the ODI, the minimal detectable change beyond normal error is 11.74. Minimum clinical important differences are said to be changes greater than 12.88. Note that standards for a good to excellent outcome following treatment are 15-point improvements on the ODI. Thank you for your attention, and we hope this helps in any future clinical practice.